We have two symposia next. The first one is sponsored by INTAS, and then we have another one by IASGCON, which will Dr. Adarsh Chaudhary will be talking on that. So I request for the first symposia by INTAS, I would request Dr. Kalyan Kusum Mukherjee to come on stage and do the honors.
Good afternoon. Thank you, organizers. Actually, this is a session sponsored by INTAS, where we will discuss, Dr. Amitabh Ray, he will discuss actually the one new drug, and which is very much promising in the paraoperative chemotherapy in CS stomach and other gastrointestinal region. And also in the maintenance region, this is S1, and a last 20-25 minutes relation from Dr. Amitabh Rai, what is advantage of this new drug over the other drug persisting in our practice. Thank you.
Good afternoon, everyone. Thank you from my institute. Thank you, Professor Mukherjee, for your kind introduction. So I have taken the liberty of changing the topic around slightly, and I've called S1 as a new friend or an old acquaintance, primarily because S1 is not actually a new drug. This is a drug coming from the Far East, essentially Japan, where it has been used for the last very many years with very good results. We all over the world, especially in India, we're waiting for this drug to arrive because our load of gastrointestinal malignancies has been growing, I'm sure you're all aware, over the last few decades. And this drug gives us an additional armamentarium to try to cope with the problem. Now, just like S1, the question is whether it's a new friend or an old acquaintance. My institute also now has a new friend on the Newtown campus, and your old acquaintances are still doing as well as they were in our Hajra campus. So with that, we'll go to the introduction. And S1 is essentially a form of 5-fluorouracil. We are all aware of 5-fluorouracil as being one of the oldest drugs being used in cancer chemotherapy. Over the years, it has become the backbone of treatment of gastrointestinal malignancies. It also has its importance in the treatment of other cancers like breast cancers and head and neck cancers. But one of the problems that we have faced over the years is the water-soluble nature of the drug, which makes it only usable in the IV format. Many years ago, there were oral formulations considered of 5-FU per se, but they did not show very good activity, neither did they show very good tolerability. So the mechanism of action, a lot of pharmacology here, but from the name itself, fluorouracil, it tells you that it basically acts by creating imbalances in the nucleotide pool, whereby causing inhibition of DNA replication, transcription, and repair. And this is essentially a diagrammatic representation of what I just told you. But what is more interesting and probably much more important from the perspective of today's molecule is what actually happens to 5-FU before it starts working. So if you see this diagram, it's a little busy, I admit that, but it's important for the rest of our presentation that we take a careful look at that. So once 5-FU goes into the system, it has two pathways through which it's basically going to go. And one is the catabolic pathway, which basically is the majority of what happens to 5-FU. So close to 85% of the 5-FU that is injected into a patient is useless because it undergoes catabolism by the dihydropyrimidine dehydrogenase or the DPD pathway to something called alpha-fluorobeta-aniline or FBAL. Now, I would request you to remember this name because this is responsible for most of the problems that we see with 5-FU. On the other hand, the anabolic or the phosphorylation pathway is responsible for the cytotoxic effects of 5-FU, and thereby that is a very, very small amount of the 5-FU that is injected, only about 1 to 3%. So as a result, in order to get cytotoxic efficacy and therapeutic efficacy, the amount of 5-FU required thereby goes up by a large amount, which not only causes a lot of non-target side effects due to the FBAL, it also causes a lot of target side effects because of the metabolites which are actually responsible for the cytotoxicity. So therefore, this is a summary of the problems. The low of bioavailability makes you give higher doses, causing higher GI toxicities, higher hematological toxicities, and the off-target, which is basically because of the metabolite, the inactive metabolite of 5-FU, you have a lot of neurological, dermatological, and very importantly, cardiological toxicities. We have oftentimes received calls from our daycare facility as well as the indoor about sudden cardiac problems that have happened in patients who are undergoing infusion with what is actually thought of being the simplest chemotherapy that you would probably give a patient. So what are the unmet needs with 5-FU then? And these have traditionally been lack of proper efficacy. We need something with better anti-tumor efficacy. We need something which is safer with lesser side effects and good tolerability, and therefore you would probably have a group which has increased patient compliance with the use of a 5-FU molecule. So with an idea towards doing that, one of the first problems that was tried to circumvent by the medical oncology community was to create effective oral bioforms of 5-FU, primarily because 5-FU infusion was for not only days, it could even be weeks, as you're aware with the ECF regime in stomach cancer. So if you have an oral congener, the patient can actually be off an IV line and probably much more comfortable. So that was the idea behind creating 5-FU prodrugs like Tegafur, UFT, FDUR, and I'll stop the discussion regarding these at this point and concentrate on the latest. One is S1, the other is capecitabine. If you look carefully, there's an essential difference between these two. For capecitabine, it is just a prodrug which has multi-step activation, the first step of which is in the liver, the second is within the tumor cell, therefore you could call it a kind of targeted chemotherapy. Very, very popular in the West. But S1, on the other hand, is not just a prodrug, it also has two inhibitors built within it. So it's basically a combination of three kinds of drugs that you're using here. And it was developed in Japan decades ago, and as I just mentioned in the beginning, they have a lot of experience with its use. So this is how the 5-FU oral congeners seem to act. So you have a prodrug which creates 5-FU within the system, and you have other drugs which could actually reduce the catabolism, the 85% pathway that you just saw, and thereby help you reduce the dose of 5-FU required to produce a cytotoxic effect. And if you look more carefully at S1, which I just told you is a combination of three kinds of molecules, what it tends to do, it also has something called utericil, which not only reduces the side effects of the system, it also reduces the on-target side effects because it has the capacity to reduce the cytotoxic metabolites in actively replicating, fast-dividing cells. So a little bit of an animation to help you understand. These are the three drugs that I was just talking about. A 5-FU prodrug, which is Tegafur, Jimerisil, which prolongs 5-FU half-life by reducing the lower the doses of Tegafur being used, and Utericil, which inhibits the formation of cytotoxic metabolites of 5-FU monophosphate in normal fast-dividing cells. So this is the flowchart that probably is important for residents if there are any in the audience at this point. So you have the prodrug being activated in the liver by CYP2A6. The 85% pathway which makes 5-FU unusable and useless is inhibited by Jimerisil. On the other hand, Utericil, it decreases the rate of conversion of 5-FU into FUMP, which is basically responsible for the on-target side effects of 5-FU like diarrhea as well as hematological toxicities. So you have multiple ways in which you are trying to modulate the efficacy as well as reduce the toxicity of the drug. As far as India is concerned, at this point in time, the DCGI has only given permission to us to use S1 in the treatment of advanced gastric cancer in combination with cisplatin. But please look out at this space because very soon you will be having many, many other approvals coming in, and why we shall see subsequently. So this is the dosage of S1. It is 25 milligram per meter square twice daily for 21 consecutive days with a 7-day rest period in between, and the cycle is repeated every 4 weeks. Typically in combination with cisplatin, these are the ways in which you try to reduce the dose. This is the BSA based prescription. So why all this is being shown and is important is because there is a lot of very good science behind the prescription of this drug, with a lot of studies going into understanding what the doses should be and how they should be modulated. Special populations, you should probably be avoiding the use below the age of 18, primarily because you don't have patient populations in the trials that have led to the approvals below this age. The good news is you could use it safely even above the age of 70 years, because the geriatric population of patients who are typically not tolerant to most chemotherapy agents seem to tolerate this drug pretty well. Moving forward, the most important part for GI oncologist is the use with hepatic impairment, and thankfully there is no such restriction unless you have a Child-Pugh-C. On the other hand, the problem with most oral 5-FU congeners is the problems of using it with a lower creatinine clearance. So the lower limit that is used here is 30 ml per minute, and that is the limit at which you would not use any form of oral 5-FU, and it's no different for S1. And there are very common adverse effects that we have also noticed in our practice. Nausea, fatigue, vomiting, even MBBS students are able to answer. Anorexia and diarrhea are typical for the class effect of 5-FU. There are very many contraindications. This probably looks like fine print to you, but what is important is you should avoid it in patients who have a known hypersensitivity to 5-FU, because at the end of the day, you may be giving it orally as a prodrug, but it's going to work only if it becomes 5-FU in the system. So you have situations like DPD deficiency where these drugs are contraindicated. As mentioned, they should not be used in patients with end-stage renal disease. Pregnancy, breastfeeding are contraindications for all chemotherapies, and so. We'll go into the second part of today's presentation, looking at the clinical trials which have helped develop this drug. There are very, very many trials. I have tried to select the ones which make some sense as far as this conference is concerned. And we'll start off with a phase 3 trial, which in my mind is one of the best trials done with any 5-FU congener anywhere in the world. It's a phase 3 conducted in 24 countries with more than 1,000 patients in unresectably locally advanced metastatic gastric cancer. So the essential question being asked here is, you know about the pharmacological advantages of using 5-FU, of using S1 over 5-FU. What is the clinical evidence of doing that? And in trying to reduce the side effects of 5-FU, are you actually decreasing the efficacy of the drug? So it was basically S1 plus cisplatin versus 5-FU plus cisplatin, a very simple strategy to understand the differences. And thankfully, there is no difference between the two as far as overall survival and progression-free survival is concerned. And the differences where they start to emerge is in the toxicity. So there is much lesser hematological toxicity with S1 with cisplatin, lesser stomatitis, lesser renal-related and electrolyte imbalance, and most importantly, lesser treatment-related deaths in the S1 cisplatin arm. So that gives us an idea from this very well-conducted, robust trial that as an option in advanced gastric cancers, this is definitely superior to the combination of S1 and cisplatin. Moving forward to the SPIRIT study, which is again a phase 3 study with more than 250 patients with adenocarcinoma recurrent or unresectable. The question being asked here is cisplatin actually important in combination with S1, or S1 alone is sufficient? This again is a rational question given the fact that S1 seems to be less toxic. You can increase the dose intensity of S5-FU with S1, and therefore you might actually avoid cisplatin, which all of us know is a very difficult drug to use in any patient. So here, again, the results are not surprising. You do see a benefit of adding cisplatin to S1, and that benefit is visible both in progression-free survival as well as overall survival, thereby giving us an idea that this probably could become something which could be a standard of care all across the world, provided the medication is available everywhere. Now, going on to the comparison of S1 with the commonly used oral 5-FU congener, that is capecitabine. Now, the Americans have pushed capecitabine into all third world countries, freely available, prices are down, we have a lot of experience with it. So the obvious question that we asked when S1 first arrived in India was, how does it compare to the available molecule, capecitabine? And this has already been studied in a meta-analysis of more than 800 patients, and the results seem to suggest that it is non-inferior to capecitabine, but definitely has a better safety profile as far as hand-foot syndrome is concerned. Now, for any one of you who has actually witnessed hand-foot syndrome. It's a debilitating problem with patients who are either on infusional 5-FU or on capecitabine, and this significantly reduces in patients who are being given S1. So this is an obvious advantage that now we are all aware of and are routinely including this into our practice when it comes to choosing a 5-FU congener in a patient who requires 5-FU based treatment. Now coming to a trial which is not looking at palliative settings. So what you saw before this was primarily advanced metastatic recurrent gastric cancers with no hope for cure. What about curable gastric cancers? How does S1 come into the picture here? And the ARTIST-2 trial is a trial which us radiation oncologists do not like. Why? Because the ARTIST trial was essentially designed to compare post-operative chemoradiation versus post-operative chemotherapy. Now, in doing so, and since it was done in the Far East, in Korea, they decided to use their standard of care, which was oxaliplatin was S1, which is the standard adjuvant chemotherapy that they use in the Far East for post-operative stomach cancers. So, in doing so, what they showed us was the combination of radiotherapy with SOX or S1 and oxaliplatin did not give any benefit, but the combination of oxaliplatin and S1 as compared to S1 alone was definitely superior and therefore has the potential of becoming the standard of care across the world. Now, coming back now to neoadjuvant, and I was witness to a discussion about how the Europeans prefer neoadjuvant and the Far East does not. So this is a study which was very recently published in the JCO in 2021, which was trying to replicate FLOT with the use of an oral congener of 5-FU. So this is the DOS protocol with a combination of docetaxel, oxaliplatin and S1. So they were using 3 cycles of DOS in the neoadjuvant setting, following that up with surgery, and in the adjuvant setting they were giving S1 alone. Now that could be one of the criticisms because the control arm did not have what is now the standard of care after the ARTIST-2, which is SOX, it just had S1. So as expected, their study definitely shows us an improvement in the progression-free survival when you do neoadjuvant docetaxel, oxaliplatin and S1 as compared to adjuvant S1 alone. But what is interesting is no difference in the 3-year overall survival. So there is food for thought here about how to modulate neoadjuvant and adjuvant in stomach cancer, at least in the population that was studied in the Far East. It does not really make too much of a difference if you give neoadjuvant DOS, which is basically neoadjuvant FLOT, and follow it up with adjuvant S1 as far as the overall survival at 3 years is concerned. But I'm sure there will be other studies looking at this in detail coming up in the future. So moving on, whether we have to have cisplatin or can we actually take oxaliplatin and replace it with cisplatin in combination with S1, the answer is a resounding yes. SOX is the new standard of care and S1 cisplatin seems to have now become of historical interest only, unless you have a patient who has liver dysfunction and therefore is not a candidate for oxaliplatin or has hypersensitivity reactions to oxaliplatin, which although not very common are extremely difficult for us to continue with oxaliplatin in those patients. What about other cancers of the GI system? You have a lot of data for S1 in colorectal cancers. As I said, this volume of data will eventually make S1 also approved in India for these indications. So you have the SOX being used for metastatic colorectal cancers and comparing it with the standard of care and has found to be non-inferior as far as the primary overall survival outcomes are concerned. And therefore, you can also appreciate the reduced incidence of certain side effects with the SOX protocol as compared to what we currently use, that is the CAPOX protocol. What about the use of additional agents like bevacizumab and cetuximab? It has been clearly shown that you can do it very easily and you can combine it. It's shown here in the SOFT study, which is again an open label phase 3 study of M-FOLFOX versus S1 oxaliplatin in combination with bevacizumab. No difference in OS and PFS, as you can see, and therefore also something that you could clearly consider given the better side effect profile of SOX as compared to FOLFOX. What about irinotecan? Irinotecan is also a very commonly used drug, especially in the second line in colorectal cancers. So you could do FOLFIRI, which is the standard for irinotecan-based regimes, or you could do IRIS, which is irinotecan in combination with S1. Again, there is no difference here as far as the ITT population is concerned, and clear benefit as far as the side effect profile is concerned. But here I'd like to stop and show you a subpopulation of this particular study, which actually is hypothesis generating. And what is that? A group of patients who were receiving second line IRIS as compared to second line FOLFIRI, who had received oxaliplatin in the past, actually seemed to do better when IRIS was used. So this probably is an indicator that there is some pharmacological difference which makes the use of oxaliplatin make the cancers more sensitive and more effective when S1 is used in the second line in combination with irinotecan. So this again will require a formal phase 3 to be able to give us better answers. But for now, this is something that we use to make treatment decisions when it comes to second line therapy. What about combination with anti-EGFR therapy? Multiple trials telling us that we can very easily do it as we do it for other cancers or other protocols. What about very poor performance status patients who do not tolerate multi-agent chemotherapy? And this is the SALTO study basically for S1 versus capecitabine in MCRC. It again shows you a non-inferiority with a different toxicity profile as compared to capecitabine. Again, the issue would be hand-foot syndrome versus hematological toxicity versus GI toxicity. The GI toxicity part is actually not very different when it comes to S1 versus capecitabine, but definitely hematological toxicities as well as hand-foot syndrome are lesser. So this, as I mentioned, are the results. The cumulative incidence of HFS grade 2, grade 3 are much lesser with S1 as compared to capecitabine. And this was alluded to a little while back when the trial discussions were ongoing, and this is something that might make S1 probably the most important 5FU congener in India, because we are all aware that the load of gallbladder malignancies in India is a huge number of patients which traditionally have come to us in stages where treatment has not been possible. But with time, we are getting more and more earlier patients who are candidates for adjuvant. And what has been the standard adjuvant across the board? It has basically been either observation or now, after the BILCAP study, capecitabine for 6 months. But the problem with the BILCAP is only a PFS benefit and no OS benefit. And as of ASCO, GI ASCO 2022, the results of the ASCOT show a startling benefit in OS when capecitabine, when S1 is used in this population of patients. So the obvious next step should be adjuvant capecitabine versus adjuvant S1 in completely resected gallbladder malignancies. So with that, we come to the key points and the last take-home messages from today's presentation. It has definitely increased efficacy at lower concentrations and lesser side effects as compared to 5FU. It can be orally administered, and therefore the compliance is much better as compared to 5FU. What about its current approval in gastric cancers? It is equivalent, non-inferior to cisplatin 5FU. It is significantly better tolerated than 5FU cisplatin. It has non-inferior anti-tumor efficacy and a better safety profile as compared to capecitabine. But again, that should be taken with a pinch of salt, because the safety is with regards mainly to hematological and hand-foot syndrome and not everything across the board. And it's definitely as effective as cisplatins and S1 as far as advanced gastric cancer is concerned with regard to its toxicity profile. So I thank you very much for a patient hearing and be open to questions.
Thank you, Dr. Rai. This is a nice presentation.